Hello, everyone. Welcome. I'm so excited you could join us today. My name is Linda Williams. I am a community outreach and training manager with Consumer Action. And on behalf of the entire staff of CA, I would like to welcome you. Today, we are presenting the truth about the COVID-19 vaccines, distinguishing between vaccine fact and vaccine fiction. Sadly, there's a lot of inaccurate information on social media and bias of sensational media about the COVID-19 virus and vaccines. And here's the deal, people. Misinformation in a health crisis can spread like wildfire. It spreads paranoia. It spreads fear and confusion, resulting in people being left unvaccinated and unprotected in the middle of a pandemic. So today we are so excited to have a group of very accomplished and truly inspiring healthcare professionals who will present us with accurate science-based information about the COVID-19 vaccines and the impact unvaccinated COVID patients are having on their healthcare systems in their state. Today we have with us Dr. Lisa Mansfield, Dr. Arlene Brown, and Dr. Keith Norris, all from UCLA Share, Trust, Organize, Partner COVID-19 California Alliance, and Dr. Maria Marquez of the Mary Center in Washington, D.C. We're going to present you this information in two segments. During our first segment, the UCLA team will present us with the importance of understanding why specific communities are vaccine hesitant and the results from one of their most recent studies. The team will also discuss with us the difference between the COVID-19 vaccines and how they work, emergency use authorizations versus FDA approval. Dr. Marquez will come on and she will explain to us the difference between COVID-19 vaccines and childhood vaccines like measles and mumps. And each will talk about the benefits of being vaccinated. Now, listen to this. According to a new analysis from the Kaiser Family Foundation, hospitalization for unvaccinated COVID-19 patients cost the U.S. health system $2.3 billion in June and July. So during our second segment, we're excited to welcome Dr. Aiken Toby from the Morehouse School of Medicine in Atlanta, Georgia, Dr. Fagan from the University of Arkansas Medical Sciences in Little Rock, Arkansas, my hometown, Dr. Compreder from the University of Mississippi Medical Center in Jackson, Mississippi, and Dr. Carlos Gio, fondly known as Dr. C at the Miller School of Medicine at the University of Miami. So instead of me butchering his name, I'm going to call him Dr. C. Each will provide us with an oral presentation of how low vaccination rates are impacting the health systems in their respective state. I am so excited about the conversation we get to have, so buckle up. But before I get too excited, I need to go over a few housekeeping items with you. As the announcer stated, when you join the webinar, you are in listen only mode, but you can use the question function on the right of the screen to type in your questions. We love hearing from you, so at the end of all presentations, Outreach Trainer Nelson Santiago will facilitate a question and answer segment. If you're on Twitter, you can use that platform to ask your questions. Our organization's handle is at Consumer Action or CA Webinars. The webinar is being recorded and will be made available to you along with the PowerPoint slides used today. You should already have in your possession the bios of each of our fantastic guest speakers. Bios were sent out on Friday. At the end of the training, you will receive a survey about today's webinar. We value your feedback as we work diligently to improve our service to you. So if you have a comment, a suggestion, or even a compliment, we want to hear from you. Also, as a bonus for attending the day, you will receive a certificate of completion. Now, let me take a few minutes to thank our sponsor for this wonderful opportunity to reach all of you. This webinar is presented as part of Consumer Action's COVID-19 Educational Project with funding from AT&T. So let me tell you a little bit about Consumer Action. We are turning 50. Happy birthday, Consumer Action. We are celebrating our birthday on November the 16th with a virtual change maker convening with Michelle Singletary as our keynote. It's going to be a blast. So help us celebrate our birthday. Please go to the website and register to join. Now, if you're not familiar with Consumer Action, you're probably wondering, well, what do you do, Linda, at Consumer Action? Well, as it says on the screen, under welcome to Consumer Action. Through education and advocacy, we fight for strong consumer rights and policies for all consumers, but especially for underrepresented, marginalized consumers nationwide. One of the many ways that we advance consumer rights is by creating and publishing educational materials on those kitchen table, pocketbook issues in multiple languages. For an example, when you're on our website and after you've registered for our convening, click on the red bar that says COVID-19 Educational Project, and that will land you on that project page. There you will find our latest fact sheet on distinguishing between vaccine fact and fiction. You can view this document in multiple languages, but this is one that you need to print, and have it available for your clients. Also, as displayed on the screen, we also created a coronavirus vaccinated outreach guide for community-based organizations. This guide shares tools and information from trusted sources. This is another publication that you should share with your community, and it's available in multiple languages. Also, while you're there, you can find fact sheets on identity theft, which has happened a lot during COVID. Fair housing rights, which is really important, especially with COVID evictions going on, estate planning, career transition, and emergency savings. Teaching your clients to start saving for those emergencies like a COVID-19 pandemic, where they don't have to face evictions. Let me go take a few minutes and go over the agenda so you'll know where we're headed. At Consumer Action, we believe in making learning fun. So we open up each and every training by testing your knowledge on the topic of the training with our most popular game, How Much Do You Know? We realize that COVID-19 is a very, very serious issue. So we've teamed up today with Dr. Lisa Mansfield from UCLA to bring you 5 true or false questions. Following the game, I will introduce you to our guest professionals that will be presenting in segment 1. Once we move through that segment, I will come back. I will introduce you to our guest professionals that will be presenting in segment 2, or what I call the rapid fire session. A question and answer segment will follow. I will come back, tell you how you can donate to Consumer Action, and then I'll wrap up. So let's get started with the game. This is how the game is going to work. We have 5 true and false, 5 questions, all are true and false. You use the question function on your panel to answer that question, either true or false. At the end of the game, the person with the most correct answers walk away with the bragging rights to How Much Do You Know? So let's launch that first poll question. The COVID-19 vaccine can affect women's fertility. Is that true or false? Don't overthink it. Don't overthink it. Speak your truth. Let us know. One more second. Okay. Let's close the poll and look at the results. 9% of you says it's true, and 91% thinks it's false. Well, we have a doctor in the house. Dr. Mansfield, what say you? Is it true or false that the COVID-19 vaccine is going to affect fertility?
Well, first, I'm excited to see so many people get the right answer, which is false, but we'll go into why exactly that is incorrect. So this is actually a false statement. To date, there's been no evidence that shows that the vaccine has caused any loss of fertility or affect the woman's ability who is fertile to thinking about coming pregnant or be trying to become pregnant. And this included through in vitro fertilization as well. And so although fertility was not specifically studied in the clinical trials, there has been no reported loss of fertility among those who participated in the trials or among the millions of women who have received the vaccine since the vaccines have rolled out. And even in the animal studies that they conducted with the COVID-19 vaccines, there was no signs of infertility as well. In fact, they did a report that looked at pregnant people enrolled in a program or a registry called Be Safe Pregnancy, and they had women in there who had started the vaccine 20 weeks before their 20-week mark of pregnancy. And even then, scientists did not find any increased risk of miscarrying for the baby if they got any of the COVID-19 vaccines. And the CDC actually does recommend that if you happen to become pregnant after getting your first shot, if you're in fact someone getting Pfizer or Moderna, to go ahead and immediately get your second shot as soon as it's ready for you to do so you have as much protection as possible for COVID-19, because COVID-19 can actually have worse health outcomes in pregnant women.
Thank you, Dr. Mansfield. I was really worried about that fertility issue. Thank you. Let's roll the second question, please. The COVID-19 vaccine contains a microchip of 5G. Is that true or is that false? Don't overthink it. The COVID-19 vaccines contain a microchip or 5G. What do you think? Okay, let's close the poll. Look at the results. Oh, wow. 2% thinks it's true and 98% believes it's false. So, Dr. Mansfield, I am fully vaccinated. Do I have to worry about a microchip being in my body?
No, ma'am. You cannot physically fit a microchip into the syringe of the vaccine. And for many of you who have gotten vaccinated with the COVID-19 vaccine or have gotten a vaccine of any type of vaccine in the past, you all see how tiny that little needle is, and the microchip is just way too big to even fit into a vaccine. So it's physically impossible to do that. But one thing I do want to dispel with this myth is to go over what exactly are in the vaccines. So as you guys know, there's the Pfizer and Moderna vaccine, which is the mRNA vaccines. And what's in those vaccines are just the mRNA that helps the body to recognize the protein spikes of the coronavirus and prepare your body to actually stimulate its immune system to get ready to fight that thing off if it enters your body. And it just has regular and normal vaccine ingredients such as fats, which help protect the mRNA, salts, and a small amount of sugar. Johnson & Johnson vaccine has similar ingredients, but it was not made in the way that Pfizer and Moderna was made with the mRNA. And it actually is made the more traditional way that we're known how vaccines are made, which include an inactivated virus to keep it from replicating once it's in your body. And it just acts as the coronavirus protein spike so that your body recognizes it and able to build immunity towards it. And there's some citric acid. That is only thing that is in these vaccines. Although we are focusing on 5G and microchips with this particular response, I also want to highlight that there's been rumors that there's fetal cells in these vaccines as well, and that's also not true. These vaccines were tested on fetal cells from an aborted fetus back in the 1980s, but they were not put into the vaccines for development. So there's no fetal cells as well in the vaccine.
Thank you, Dr. Mansfield. Let's roll question 3. Oh, wow. The COVID-19 vaccines enter your cells and changes your DNA. Is that true or is that false? Okay, audience, I need to know from you, do you think this is a true statement or a false statement? The COVID-19 vaccine enters your cells and changes your DNA. Okay, one more second. Let's close the poll and look at the results. Okay, so 3% of you think that the COVID-19 enters your cell and changes your DNA. 97% is saying that that is false. Let's ask Dr. Mansfield. So Dr. Mansfield, I am fully vaccinated. And if my doctor determined I need a booster, I am getting it. So is my DNA changing? And what am I changing into?
You're not changing into anything but a healthy person ready to fight that coronavirus if it happens to enter your body. So this one is in fact false as well. As I mentioned in the previous responses, the COVID-19 vaccines are designed to help your body's immune system fight the coronavirus. And it does so with those virus protein spikes that are in your body through the vaccine. So the mRNA that is in both the Pfizer and Moderna vaccine does enter your cell. However, it does not reach the heart of the DNA, which is called the nucleus. And so all the mRNA does is that it gets into the cell to help with their proteins to help stimulate your immune response. And as soon as your antibody or your immune response is going to work, it then quickly breaks down and then gets out of your body within a couple of days or so. So it doesn't even stand a chance to stay in your body long enough to do anything to your DNA. So your DNA is not affected at all. And once your immune system's been stimulated, the body permanently gets rid of the material of the mRNA that was in the vaccines.
Great. Thank you, Dr. Mansfield. Just a couple of more questions. Question number 4, please roll it. This is a good one. I've already had COVID-19 in the past, so I can't get reinfected with the virus again. Audience, what do you think? Is that a true or a false statement? Come on, speak your truth. Speak your truth. Okay, one more second. All right, let's close the poll and look at the results. So, Dr. Mansfield, 9% of our audience think that this one is true. Are they correct?
So this one is also false. And so as we've been hearing in the news, the Delta variant. So all we're hearing is that the coronavirus has actually mutated. And so if you were unvaccinated or still are unvaccinated and you happen to get COVID earlier this year before the Delta variant made its way worldwide, you may have gotten infected with the Alpha variant or other variants of the COVID coronavirus. And so you have some protection from that last illness and infection, but you may not have the response or antibodies to protect yourself against the Delta variant. So there is a likelihood of you getting sick again or reinfected with the coronavirus because it may be a different strand of it. While it's rare, there has been people who have been reinfected with coronavirus and they have gotten sick. So there's been encouragement from the CDC for people to still get vaccinated because it will provide extra immunity in your body against COVID-19. And there's recent evidence that has come out that show that people who get protection from being fully vaccinated compared to those who already had COVID-19, they're actually more protected against the coronavirus. So those who weren't vaccinated and already had COVID-19 were almost 2 times as likely than fully vaccinated people to get the coronavirus again.
Thank you, Dr. Mansfield. Our last question. Please roll it. Okay. COVID-19 vaccines aren't affected against the Delta variant since vaccinated people are still getting COVID-19. So, audience, what do you think? Is this a true or a false statement? Speak your truth. Okay, let's close the poll and look at the results. Okay, so Dr. Mansfield, 89% of our audience think that this is a false statement. Are they correct?
They are correct. I'm sorry, let me read this. I'm sorry, I read it one more time. Oops, sorry, the question went away.
The question, I'll read it to you. COVID-19 vaccines aren't affected against the Delta variant since vaccinated people are getting COVID-19. So,
oh, yes, sorry. That is false. So they are actually effective in protecting against the Delta variant. And so while they're not 100% effective in making sure you don't get it, because as we've been seeing in the news, there's been a lot of breakthrough cases coming through with some people getting vaccinated. That percentage is actually relatively small than those who are not vaccinated at all. And so you may still get the coronavirus because of the Delta variant, but by being vaccinated, you actually have a level of protection to protect you against getting severely ill, which can result in hospitalization or death from getting infected with the Delta variant. So it's not an end all be all saying if you're vaccinated, you won't get the Delta variant at all, but it severely reduces your chances of being hospitalized or dying from COVID-19.
Great, Dr. Mansfield. Thank you so very much for that. Okay, so now we're going to move into our main section, section 1. And I'm going to introduce to you the speakers in the order that they will be speaking. I'm going to tell you a little bit about them. This is where you break out those bios that we send you so you can follow along. Our first speaker is Dr. Lisa Mansfield. You just met her when during the game. And let me tell you a little bit about her area of research. Her area of research focuses on vaccine uptake behavior among minority adolescents and adults. Dr. Mansfield has conducted several studies examining factors influencing HPV vaccine uptake uptake among adolescents, including the role that parental HVP knowledge plays on a parent's decision to vaccinate their daughter. Our next guest speaker is Dr. Arlene Brown. Dr. Brown is a professor of medicine in the Division of General Internal Medicine and Health Services Research. Dr. Brown's research focused on improving health outcomes, enhancing healthcare quality, and reducing disparities for adults with chronic conditions such as diabetes, cardiovascular disease, and strokes, particularly those with complex medical and social needs. Following Dr. Brown would be Dr. Keith Norris. Dr. Keith Norris is an internationally recognized scientist and health policy leader who has made major contributions to diversity, equity, and inclusion while addressing disparities in contemporary society. His research interests focus on hypertension, chronic kidney disease, and marginalized population, enhancing community academic partnership, and increasing diversity in biomedical workforce. Following Dr. Norris will be Dr. Marquez. Dr. Marquez is a board-certified pediatrician and medical doctor of Mary Center Fort Totten Health Center in Washington, D.C., Ward 5. She is also a professor in the General Pediatric Division of the Department of Pediatrics at MedStar Georgetown University Hospital. She is also one of the co-founders of the District of Columbia Oral Health Coalition. So welcome each of you to the webinar. Let me turn the webinar over to Dr. Mansfield. Give me a second to give you the mouse. Dr. Mansfield, you have the mouse. You are ready to go.
Okay, thank you so much, Linda, for that warm introduction. And so UCLA team, as Linda mentioned, we'll be presenting 2 segments today. And so this first part, I will go over some of the study that we did earlier this year before the vaccines rolled out. And particularly, we looked at COVID-19 vaccine hesitancy and deliberation, or the thought process of making a decision for vaccination in multi-ethnic communities. I don't think I have control. It's not advancing for me.
Well, you listed twice. Now you should have control. Ah.
Yeah, there we go. Okay, so as I mentioned in the first segment, we'll go over our study and talk about what we did earlier this year and at the end of 2020, looking at the community's different attitudes and acceptance of COVID-19 vaccines and what hesitancy in the decision-making look like. And then I'll turn it over to my colleagues, Dr. Brown and Dr. Norris, to address some of the concerns and myths that we've heard about COVID-19 vaccines since doing this work earlier this year. Okay, so before we jump into what we found and how we did our study, I know many of you have been hearing the word COVID-19 disparities. And so what exactly does that mean? Well, for one, it's different for many different groups of people. So it's different by different race and ethnicity groups, as well as people of different ages and people from different social economic backgrounds. And when we use the word disparities, we're looking at how the COVID-19 outcomes are being impacted by things such as structural racism. And those can include employment, people's ability to have housing and afford it, education and poverty, the resources available to them in their community, which will eventually impact their ability to access care, discrimination in healthcare services, which is unfortunately very common in our communities, and it can affect your willingness to even want to go see a doctor because you want to avoid those type of events. And this also has to do with different chronic diseases that already impact our communities and our life expectancy. And so at the time of this study, this is what the map of California looked like. So as you can see down at the bottom in Los Angeles County, we are really dark. We're on the darker end of the stick. So we had a lot of cases going on. And that specifically at this time, there had been over 3 million COVID cases and roughly 60,000 deaths in Los Angeles County. And as a diverse county, the COVID-19 disparities in Los Angeles were significant, where there were many cases and death rates that were twice as high for those who were living in high poverty areas and those highly comprised of racial and ethnic minority communities. And also at the same time, we're seeing that there was a lot of health inequities at the time. So back in February, this is what the vaccine uptake versus the number of COVID-19 cases looked like. And so here in the darker blue, those colors reflect higher proportions of cases in places like South LA and Lancaster, which both regions are comprised of a majority of racial and ethnic minority residents and are high poverty areas. However, here on the left in these green sections, we see these lighter green colors. There are these same places that were highly impacted by COVID-19 cases also had lower rates of vaccination in the hardest hit regions. So to this end, our team got together and we wanted to understand what were those factors contributing to multi-ethnic communities' hesitancy, the process of making a decision for the COVID-19 vaccines, and their acceptance of COVID-19 vaccines among multi-ethnic groups that were at high risk for COVID within Los Angeles County. And so we got our team together and we did community engaged methods, which all that means is that the community helped to inform the way we did our study, informed us how we were going to recruit people for our study, gave us feedback that we incorporated to refine the study, and then also different ways that we could share our findings out with the rest of the community. And we specifically targeted LA County community members that were at high risk for COVID-19. And this included essential workers, different racial and ethnic groups facing a high burden of COVID-19 or other related health issues, and those living in low income, high poverty zip codes. We actually had conducted a 2-hour virtual focus groups from November 2020 to January 2021. And just to put in perspective what this looked like, what was going on in the world as we were also doing our study. So as I mentioned in November, we started our focus groups, but at the same time, Pfizer and Moderna had just released their vaccines for EUA approval, and we'll go into that later in presentation on what that means. And that was open just for healthcare workers. And then shortly thereafter, we finished our focus groups, but at the same time, LA County had just opened eligibility for people over 65 to start getting the COVID-19 vaccines. And then shortly thereafter, Johnson & Johnson approved their vaccine. So as you can see with this timeline, there was many changes going on as we were doing our study. So it might have affected what our participants were thinking about the vaccines and their concerns as this information was changing day by day. And then for our focus groups, we developed our focus group questions based on other research that looked at vaccine hesitancy with other vaccines, and then also discussions with our community partners. And we actually trained facilitators who represented each racial and ethnic group to lead the focus groups. And particularly, we did this not only to promote comfort, to make sure people feel comfortable talking about issues in their community with someone who understood where they were coming from, but also to be able to understand the different nuances and cultural dialects and language in the communities as well. And so we conducted 13 focus groups in total, and we separated them by age. So we did a group of under 50 years old and then those over 50 years old, and also by race ethnicity. So then we ended up having 3 groups with African American or Black participants, American Indian, Native American participants, and Latino adults, in which in the Latino group, we did our focus groups both in English and Spanish. And then we had 2 groups with Filipino and Pacific Islander adults. And then we just did a thematic analysis to be able to take the rich data that the participants shared with us and give some categories about how it described what they were explaining to us. And so this is what we learned. There was 4 major points that came out from our focus group interviews. And I'll present each of them with respective sub-themes and quotes in the next couple of slides. But these included vaccine knowledge, misinformation, and concerns, vaccine equity, being able to access the vaccine and afford it, mental health and the hope. The people had hope in the vaccine delivery, and then desired engagement and outreach. So the participants actually told us what they would like to see to promote COVID-19 vaccine outreach in the community. And so first with the vaccine knowledge, misinformation, and concerns. So overall, across all the groups, everyone was seeking critical and basic information about COVID-19 vaccines, including data on how safe and effective the vaccines were, in addition to the representation of different people with different illnesses and race ethnicities in clinical trials. And one participant described here in the upper right-hand corner, there was concerns that there was going to be long-term effects and that the clinical trials did not include enough Pacific Islander, women, people of color, and those with health disparities. And although a Pacific Islander participant mentioned this, this was kind of a common concern across all the groups. And these concerns were largely influenced by beliefs that the vaccine was just made too quickly. Participants also described inequitable factors related to vaccine access, which caused a lot of confusion in the vaccine allocation process. There was also reports of conflicting information from the news and social media, which fueled misinformation within these communities. And there was requests that healthcare professionals who can actually be able to explain the information would have been better for people to receive their information from. We also heard concerns for acknowledgement of people's personal medical experiences, including racism and discrimination. And as we see here in this quote, this one participant mentioned that for people who have been let down by the system in the past, they will hope there's a little compassion, understanding, and patience, and not treating someone as less than because they are impacted by past situations. And so this participant was mostly getting at just acknowledging that there's hesitancy in these communities because of current racism and discrimination that they experience in the healthcare system. And then we also heard historical, medical, and government mistreatment and mistrust among some of the participants, which made them feel reluctant about getting the vaccines. And a lot of references were made to the Tuskegee experiment, but each group sadly had their own experience or historical experience that they described where there was unethical mistreatment and mistrust in their communities. And then with vaccine equity and access, this was a huge, accessibility and affordability. This was a huge barrier to COVID-19 vaccines. And this included language barriers, transportation, and documentation status for those who were undocumented. And participants desired equitable vaccine access for all populations in their community, including those in jail, the elderly, and those in foster care, as well as the homeless. There was also issues with technology limitations, so people having access to phones and internet, as well as employment barriers with people who actually did want to get the vaccine, but feared that they couldn't get time off to get the vaccine or get days off to recover from the side effects. So this created additional barriers and made many perceive the vaccine allocation process as burdensome. And then lastly, for participants with older relatives who wanted to get the vaccine, they perceived a lot of barriers in the vaccine allocation process for seniors and even described it as lots of hoops to jump through for seniors, and it shouldn't be that way. And with mental health and hope in vaccine delivery, we heard many stories about the toll that the pandemic played on people's mental health and just day-to-day hardships. As this one participant described, a lot of people in their community are essential workers, so there was a lot of anxiety just to go to work and make a living because they just didn't know if they were going to get COVID or if the people they'll come in contact with had COVID and if they're following proper social distancing and other COVID-19 vaccine guidelines. And however, though, despite these mental health concerns that we heard and also hardships to the pandemic, there was hope that the vaccine would allow people to go back to normal. And lastly, for desired engagement and outreach, so participants describe what their ideal outreach would look like, and that included capacity building and investment of trusted community leaders to give out information and education about COVID-19 vaccines. And these trusted leaders include faith-based individuals such as pastors, local clinics, and cultural organizations. Participants also requested alternative ways to access the vaccine, such as mobile clinics, or having people come to the community to be able to start vaccinating people and give out information and make appointments, especially for those who are not easily reached. And there was also discussion amongst the groups in engaging different generations within the family and network as advocates. That's including children, grandchildren, to share information with elders and help them get signed up for vaccines, which seems to resonate with increasing vaccine acceptability and wanting to get the vaccine in multi-ethnic communities. And the key takeaways that we got from this study is that vaccine hesitancy is complex and multifaceted. So there's lots of things that go on to it other than just being concerned and afraid to get the vaccine. And it includes being able to make a decision for the vaccine, access it, and also have the acceptability to get it. And in order for us to improve vaccine outreach and engagement, we need to reduce structural barriers in parallel with increasing different resources and funding to support vaccine outreach and engagement. And we learned from this focus groups that we need to collaborate and invest in and empower trusted community leaders to share information and provide navigation support. And this included being able to answer the community's concerns about the vaccines, like what we're doing here today, and also helping them to navigate actually signing up for the vaccine when it was at the time of the study their turn to get the vaccine. And there was also a lot of need for representation and data transparency for all high-risk groups to communicate vaccine effectiveness. We commonly heard our participants say, well, do people in the vaccine look like me? Or do they have this type of group? Do they have this person with this medical condition? And so there was this desire to see the data for different illnesses, but also race ethnicity representation as people were making decisions for the vaccine. And there was a big concern about misinformation. And so there was key takeaway here is that we needed to dispel misinformation so that people can make the right decision for them and not a misinformed decision. And lastly, we had to acknowledge that mistrust is based on those things have happened in the past, such as Tuskegee experiment, but also those things that are currently happening in society with Black and Brown communities and different persons of colors in the sense of the discrimination and racism that they still ongoingly face in healthcare system. And so it was important that we learn to show empathy, understanding, and respect to these communities. And so from this focus group, we actually did many things with it. So the first thing that we did was we actually used the focus group data to actually do community engagement. And a lot of the information that was shared from the community informed the materials that we made to give back to the community. And this was included developing town halls with community partners, publishing findings that our focus group participants shared with us in local ethnic media articles like La Opinion and LA Sentinel. And we also developed community-friendly slides and materials like frequently asked question sheets and reflected on top questions and concerns, including myths. We also had implications for community education. So we made this cool FAQ sheet here, which we heard in our focus groups time and time again. It needs to focus on like the community reason for getting vaccinated, not just a personal reason to get vaccinated. So when we made our FAQ, we made sure to include that you're protecting not only yourself, but everyone around you. We also addressed culturally specific concerns. So as you see here at this fourth bullet point, there was lots of concerns, particularly in the Latino community, about documentation status. So we made sure to mention that in our FAQ as well. There was also, we also made sure to address vaccine safety and efficacy, specifically in multi-ethnic people, and that include their race ethnicity makeup, but also chronic illnesses that are very prominent in our communities as well. An example of this is a common question, like I said, we said is the vaccine safe and effective for someone like me? So we made sure to show that yes, it is. And we're not just saying that because we want to protect you, but there was actually a good representation of different races and ethnicities in the clinical trials to make sure it truly was safe for someone like them. And we also developed a policy brief. So this focus group data took us all the way to the policy state level, and we were able to share our results and develop a policy brief that we disseminated to locally, regionally, statewide, and even nationally. And lastly, our focus group interviews really gave us the leverage to impact and think of implications for future programs. And as we currently are doing in the UCLA, we have a campaign called the Get Out the Vaccine campaign, and it's a current partnership that we have with 34 community-based organizations, and we have people go out in the community and register people for COVID-19 vaccination. As you guys remember from the focus group interview, a key thing that our participants said they wanted is someone to go out to the community and educate them on that. So we took what we heard and actually made it happen. And so we hired canvassers that go door to door in high traffic areas like the supermarket, and also through phone banks and phone calls to reach people to address their concerns about COVID-19 vaccines, and also be able to register them for getting the vaccine as well. And our canvassers are trained to educate about the COVID-19 vaccines and to have effective vaccine messaging to help dispel the misinformation in our communities. And we're able to track all contact with the community. So if there happens to be a time a canvasser goes out there, they didn't get to reach that person, it's logged in the system as that, and we're able to go back and try to re-reach them. And then the cool thing about this project is not only addressing our community vaccine needs at this time, but we're also providing social services support, such as rent relief assistance, and giving the community resources to learn more on how to get assistance with other things that are affecting them at this time. At this time, I will turn it over to Dr. Arlene Brown and Dr. Keith Norris to go over our second segment, which will dispel common COVID-19 myths that we've heard in the community.
Great. Let me give Dr. Norris and Dr. Brown control of the. You have
Thank
control.
you very much. I'll get going. This is Dr. Norris. I'll get going. Thank you very much, Dr. Mansfield. And for the panelists, the attendees, it's just a pleasure to be here, and thank you for the opportunity to share with you the information that we're able to provide today. So this is just looking at a glance as of a couple of days ago. Over 225 million cases worldwide of COVID-19 that have been recorded, and over 40 million in the United States. Importantly, vaccines, when we look at data on vaccines, fully vaccinated adults age 65 and above, almost 95%, okay? And much less likely to be hospitalized with COVID-19 than unvaccinated adults. So that's the key. Less likely to be hospitalized, less likely to die. When we look at this data nationally, a little over 200 million Americans have had at least one dose of the vaccine, almost 65%, and over 180 million Americans have been fully vaccinated, a little over 50%. So we still have a ways to go to get to 70, 80%, which are the numbers we hear for herd immunity, but we're slowly getting there. When we look at deaths, almost 5 million deaths worldwide from COVID-19. I know we hear a lot of stuff that the media is making it more dramatic than it is, but I think that's pretty dramatic. Over 660,000 deaths in the United States. That's a lot of people. Importantly, almost 3 million people have been hospitalized. And the hospitalizations are really critical because this is 3 million people hospitalized that our health system had not thought about or planned for in regards to people being hospitalized. And so what we're seeing is, as more people get hospitalized, a lot of times we don't have the beds in different hospitals, we don't have the healthcare workers, and that can impact the care of patients with COVID, but it also impacts the care of patients that don't have COVID, or the ability for patients who don't have COVID to get into the hospitals. When we look at breakthroughs, what are called breakthrough infections where people are hospitalized, so almost 13,000 breakthrough hospitalizations and 3,000 breakthrough deaths. But we have to remember, there was never an expectation that a vaccine would prevent everybody from getting sick and something bad happening. As a matter of fact, I think most people were amazed when originally we saw numbers like 95% effectiveness and 97, 98% effective in reducing hospitalization or death. The flu vaccines are usually effective in like 60% of the people. So this is like really, really different than compared to many vaccines that we have. Right now, the vast majority of deaths are occurring in people who are not vaccinated. So yes, people who are vaccinated can still get COVID infection, but they usually don't end up dying from it. And that's why we have the vaccine. The vaccine was made not to prevent people from getting sick, to prevent people from being hospitalized or dying. If people just got sick like the regular cold, we wouldn't have a vaccine. So what are some common myths? As we heard from Dr. Mansfield, the vaccine will not alter your DNA. There were no skip steps in the process. So everything went fast because a lot of money was poured into making this process happen quickly. Normally, we don't pour that much money into processes like this. And so we finally got full FDA approval. And the full FDA approval takes a while because A, they're looking at data for safety and efficacy, but the FDA also has to look at data around how the vaccine will be stored, transported, administered, and things like that on a long-term basis, which is different than how it's done in an emergency basis. A lot of people have concerns about potentially getting COVID from the vaccine, and that does not happen. Now, there were some vaccines in the past which are called attenuated virus vaccines, and so they weaken the virus, but if a weakened virus gets in your body and your immune system's not good, you can actually get the disease. That does not happen with the COVID vaccines that we have. But what the vaccine does do is reduce our chance of catching COVID-19. And if we do happen to catch it, it really reduces our chance from becoming very, very sick from it. It doesn't prevent everybody. And again, many people who are getting the vaccine have many medical conditions, are very old, and so would be at increased risk from succumbing to a COVID-19 infection. Again, as we heard from the question and answer in the beginning, the vaccine does not affect fertility. What it does is it teaches, the vaccine goes into the body, goes to the cell, it teaches our body how to recognize and respond to COVID-19, and then it disappears. So the good news is there are no significant long-term side effects to date. Every vaccine, including COVID, has some side effects. The side effects of the COVID vaccine are much lower than almost all the other vaccines we have, from mumps and measles to flu vaccines to a variety of others. What we do know, what we definitely know, is there are many long-term side effects of COVID infection. So that we do know. Right? So a lot of people are worried about what might happen in comparison to something that they know is going to happen. Right? So that's what we want to focus on. So the benefits of the vaccine protect you, and for people who feel that they're immune and that nothing can bother them, it can also protect your family and your community. So maybe one of those three might be important for you. All three are almost 100% effective in preventing COVID-19 hospital admissions and deaths. Almost 100%. That is like, we don't have anything in medicine that's like anywhere near that number for anything, right? So people get pneumonia, we can give penicillin. We don't have numbers like this, right? Being unvaccinated, again, can increase our risk of getting COVID-19, and COVID-19 we do know has long-term complications, lots of long-term complications. Sort of arthritis type problems, heart problems, brain problems, memory, things of that. So a lot of complications from the infection itself. So again, were people like me part of the vaccine trial? Whoever you are, the answer is pretty much yes. So there are over 100,000 people, and unlike many clinical trials where only people who are healthy, doing well, are allowed to be participate in the trial, here people were allowed to participate from a variety of different ages. Early on, it was adults, all different racial, ethnic backgrounds, multiple chronic medical conditions, diabetes, asthma, heart disease. And so that's where we have all of our data from, right? And we see here broad representation, fairly equal to representation within the country. Okay? And so that's very important for people to know. So why is it particularly important to vaccinate communities of color? Well, I think as many people on this webinar are aware, particularly early on, the hospitalizations, the death rates, the infection rates, anywhere from 2 to 4 times higher in communities of color. 2 to 4 times higher. And at that time, particularly when the vaccine was first coming out, a lot of rich people who never, have probably been in a community of color, maybe in their life, were running to those communities to get online to get vaccines. So when you see people do that, you need to say, there might be something there. Now, why is that? Well, part of it is communities of color, for a lot of the reasons Dr. Mansfield outlined, related to structural racism and inequities in the distribution of resources and support services based on the composition of communities by race, ethnicity. We see much higher rates of underlying health conditions, less wealth and resources, more need for high density housing, and a lot of other factors that lead to increased risk, exposure, and greater likelihood of infection and complications. So our goal is to try to make sure we can have as many people in communities of color vaccinated, and to try to achieve what we call community immunity through vaccination, to make sure we're protecting the most vulnerable among us. Well, what about pregnant women and children? So far the data looks just as good for pregnant women, but importantly, pregnant women are one of the groups that do very, very badly if they get COVID infection. They do very badly. So there's increased risk of a woman dying with COVID if she's pregnant compared to other women her age who are not pregnant. And that also could lead to complications for the baby as well. If a pregnant woman gets the vaccine, the antibodies can be passed on to the baby, and the baby can then be protected. It does not cause infertility or reduce the chance of getting pregnant. Matter of fact, in the first study, the early studies, individuals who were pregnant were not allowed to be entered into the study. But during the study time, a lot of people got pregnant, and they all did very well. Now, with the new data, based on new studies, children ages 12 to 15 can get the Pfizer vaccine, but parents do need to provide consent for their children to get the vaccine. Okay? In children, rare circumstances, children who are emancipated minors can get the vaccine for themselves. So what about if you've already had COVID-19? Should you still get the vaccine? And the answer is yes. And the reason is, as Dr. Mansfield said, while having a COVID infection does give you some immunity, it tends to go away quicker than the immunity from the vaccine. So the vaccine can prolong and enhance your immunity. And in fact, not only does the vaccine give you additional protection to help against some of the variants, but there's data that shows that if you've had COVID-19 and you get the vaccine, that you might even have more protection, right? So you want to take advantage of that. Now you need to wait. If you have a COVID infection, you can't get the vaccine at that time. You have to wait for a couple of weeks until you're feeling better and the virus has gone away, and then you can get the vaccination. But we want people to get it less than 3 months after the COVID-19. So usually it's about 2 to 3 weeks after, but less than 3 months after you've had the COVID infection. Now, importantly, the COVID pandemic is not about you. Let me try that again. Importantly, the COVID pandemic is not just about you. I know lots of people think it's about themselves. It is not just about you. It's about your family members, your neighbors, your friends, your community. It's like driving under the influence. You may feel like you have the right and you're really good, and even if you're drunk, you're okay. We have laws that say you cannot drive under the influence because it's more than, because A, we want to protect you, but importantly, we want to protect other people too. So yes, there are laws to protect people and try to keep people healthy. The CDC recommends fully vaccinated people can resume most regular activities. At UCLA, school just opened. All students and faculty are requested to be vaccinated if they're going to be on campus. If you're in the outside, you don't have to wear a mask, but if you're in a closed setting, then you do need to wear a mask. Their policies are different in different places. If you've been around someone who's COVID positive, you should get tested to make sure you haven't become positive yourself, even if you have no symptoms, right? And so then we want people to wear a mask for 14 days or until you get a negative COVID test, just to make sure you're not giving it to somebody unknowingly. And if you test positive, then you need to be quarantined for 10 days or until you no longer have symptoms and test negative. And what about these? Actually, I think I'm going past. I'm going to turn this over to Dr. Brown before I do all of her part of her talk for her.
No worries, Dr. Norris. So can you guys hear me?
Yes.
Great. All righty. So I'm going to talk a little bit about viral variants and a couple of other topics that were raised in questions that came to us. And I think a lot of people are concerned about these variants or mutants of the virus. A variant's a form of a virus that evolved from or changed from the original form. And once a virus enters the body, it makes more copies of itself. The more copies, the more chance it can change. And the changes are called mutations. A virus that has mutated is referred to as a variant. And this is just what viruses do. This is their livelihood. It's their job to change and mutate so they can outrun your body's immune system. So I don't think I have control of the slides. Here we go. So for COVID-19, the Delta variant has received a lot of news recently. This variant also has the long name B.1.617.2, and it's a mutation that was first identified in India in December of 2020. It appears to be much more contagious and spreads quickly. So it's about twice as contagious as the original COVID-19 virus, and it appears to cause more severe symptoms and hospitalizations, including in young people and otherwise healthy people. If you can recall, the original virus, a lot of times people said younger people often had relatively few symptoms. And what we're seeing with the Delta variant is we're seeing a lot of young people who are more symptomatic from COVID-19. Now, back in July, the Delta variant was the cause of 83% of new COVID-19 cases. Recent data from a few, really this week in September suggests it's over 99% of COVID-19 cases in the US. So I think a question that comes up a lot is, if vaccinated people are getting the Delta variant, should you still get vaccinated? And the answer is absolutely yes. The COVID-19 vaccines are really important for protecting yourself and others in the community from COVID-19 and the variants. It looks like the COVID-19 vaccines are very effective against the Delta variant and help reduce severity of disease, hospitalizations, and death. So if you already had COVID-19, should you still get the Delta variant? As Dr. Norris mentioned, if you've had the disease, COVID-19, you have some protection from getting COVID-19 again, even with the Delta variant. But we really don't know how strong that protection is and how long it will last. And this protection can really vary a lot from person to person. And because of this, physicians and scientists really recommend that people who have had COVID-19 go ahead and get vaccinated, because this will give you more protection against the Delta variant. Now, can a vaccinated person still get the Delta variant? Yes. However, when people are vaccinated, people who've been vaccinated test positive for COVID-19, most either have no symptoms or have very mild symptoms, and it rarely results in hospitalization or death. As we noted before, 99.9% protection against death. COVID-19 vaccines are the best way to protect people from getting seriously ill with the virus. It reduces hospitalizations, it reduces the length of hospital stays for those who are hospitalized, and it just dramatically decreases your risk of dying from the disease. Back in July, there were 65,000 breakthrough cases. So those are people who were fully vaccinated but got COVID-19, and that was among 160 million people who were vaccinated. More recently, and what we've seen is that less than 1%, it's actually 0.04% of vaccinated people reported breakthrough cases. Those numbers haven't changed very much, and in September, it was less than 0.007% of vaccinated people who had breakthrough cases. And the rates of death were even much, much, much lower than that. And contrast that against the risk of death for people who are unvaccinated who get COVID. I want to briefly touch on emergency use authorization. We've already talked a little bit about this, but I want to really highlight the fact that, we're now seeing Pfizer going from under emergency use authorization to full FDA approval, and we'll see that in the coming months for the other vaccines. And just to clarify, in an emergency, the FDA can make a product available based on the best available evidence without waiting for all the usual evidence that's needed for FDA approval or clearance. But we should still emphasize that no steps were skipped in developing these vaccines. So they went through the same steps, but in a somewhat different order, in that they actually made the vaccine available and started mass manufacturing it before there was emergency use authorization, so that when there was emergency use authorization, the vaccine could be widely distributed. And the FDA basically has to weigh potential benefit of the vaccine against risk associated with the vaccine. Now, with full FDA approval, what you see is that all the same steps were used, and the FDA has actually reviewed additional data on things like vaccine manufacturing, long-term storage, conditions for storage, things that are different from what you might focus on in the case of the emergency. And this data takes a longer time. That's why it's taken some time to get final approval. Now, the last thing I'm going to focus on is the issue of booster shots. So There's been a lot of information in the news about boosters and third doses, and I want to distinguish the third dose that's recommended for individuals with weakened immune systems. So people 12 and older who have weakened immune systems. So if you've had an organ transplant, if you are a cancer patient who's undergoing chemotherapy, patients with AIDS or HIV that's uncontrolled. Those are all people for whom we recommend a third shot as usual therapy for Pfizer and Moderna. And that's actually 20 to 8 days after the second shot. This week, just yesterday really, it was announced that people over the age of 65 can now get a booster shot, and that should be 8 months after the second shot of Pfizer or Moderna. Right now, this only applies to the Pfizer and Moderna vaccines in the US. I want to highlight the fact that this information is changing in real time. It's going to change very quickly. We anticipate over the next few months, and we anticipate that we may see a broader swath of the US public eligible for a booster. But remember that for certain groups, a third shot is now the usual course of therapy. So I'm going to stop there, and we'll hand it over, I think, to Dr. Marquez, who will be talking about COVID in children and adolescents.
Great. Let me give Dr. Marquez control. Go ahead, Dr. Marquez.
Okay. Hi, everybody. It's an honor to be here with you, with this amazing team, and also with you, everybody who is with us at this moment. So I'm going to talk a little bit about who I am and where I work. I work at Mary Center, that is an organization, federal health qualified center, and we have 5 clinics in the community of DC and Maryland area. One of the things I want to make sure that I mention this is because of historical reasons, 60% of our patients self-identify as Latinx population. And this has kind of embarked us in a very amazing journey to make sure that we promote vaccination and help as possible during these very hard moments that we're all living at this time. So let me see if I can go next. Trying to do. Okay. So why I'm going to talk a little bit about personal story. I've been impacted in different ways with infections that have been at this moment prevented with vaccination. I am a pediatrician, so I'm a 100% believer vaccinations are an amazing tool that humanity had created for many, many, many years to prevent serious infections, lethal infections, and infections that can kill us, that can get us with chronic sequelae and changing our life and health forever. And so I'm going to tell you, like, I had experienced chicken pox, and I do have skin marks that you can see if you meet me in person. I was 5 years old. I remember vividly this infection. I was really sick, actually, even though I was a kid, and it's supposed to be milder when you're a young person. At that time, we didn't have vaccination, so I was one of the children who got infected with this disease. I also had mumps when I was a child, and I still remember vividly as well when I got that infection. I remember when I had this acute otitis media in my life, and they were all related to the main source was the strep pneumo at that time. Where I grew up, and now we have prevention, a great vaccine for that as well. One of the main things I want to make sure that I share, I lost one of my classmates in medical school because he got chickenpox infection as an adult, and he did have a chronic condition that may have changed his immune system in some ways. And he died with chickenpox pneumonitis, and at that time we didn't have vaccine access to varicella. So it was, and I have also lost a dear friend with flu infection when she was 42 years old, and in 2015, not vaccinated at the time, even though the vaccine was available, and she also had a chronic condition that may had changed her immune system, and she died in the matter of 2 weeks. And then again, I've been exposed to many diseases that we do have vaccines today to prevent. And we're going to keep talking a little more about personal experiences in some way. So that's the reason why when they say vaccines are available for a group of people like me in the healthcare system, and I got my first dose December 27, 2020. One of the first one, I have no questions about the marvelous tool that we started implementing for our communities. And I was there, no hesitation about it. And the government progressively made it available to everybody. And we already mentioned that there's no need for showing insurance card, no social security. We may ask you an ID to make sure that we're recognizing your name and that you are Maria Marquez, for example, and that you have 2 doses. If anyone asks, you already have them. I consider this vaccine a miracle vaccine because it was created in a very short time in an emergency situation. Again, I believe vaccination is a miracle tool for prevention of diseases and actually improving our health life and health style and life in general for all of us. And is, as we say, Dr. Norris mentioned, it's not about us as a person, it's about everybody. And I do see vaccines as responsibility, not a choice, as my life experience have really molded this belief. It is, not only the necessary prevention modality, but it's also improving our lifestyle. Like when you get taxes, it's always to get a better lifestyle for all the community. It's not just for you. You're going to get better education, better transportation, and a lot of things that are really communal, really well-being. And this is how I see vaccinations. So I want to make sure I added something to make sure that we all attentive to our conversation. So when do you think happened the first mandate of vaccination in the US? As we are experiencing today, right? We don't have an answering process here, but I just want to make sure you are alert. But it was during George Washington time in 1777. He mandated vaccination of the soldiers that were in the Continental military team, and they're vaccinated or inoculated around 40,000 soldiers with a smallpox virus. That is a disease that is eradicated of the world. We don't have that disease today, thanks God. It's one of the few. We have 2 diseases that have been eradicated of the world, but this is one of them. And it is very interesting because he described in his command to the President Hancock, he stated it's going to be a little bit discomfort. It's not, it was an attenuated virus from lesions of other people who got the disease, and he described it beautifully that it's not a perfect thing. You may feel sick, but at the end, it will prevent people to get the real disease and very sick and sometimes even die from it. And he thought about this because there was a global movement to do this, and there were already discoveries in the world about, especially in the UK, where they were already figuring out how this inoculation could prevent the disease. And he also had smallpox when he was a teenager in Barbados. So he thought that he was ready to have some protection against the disease. So he wanted his soldiers to be ready to fight for the country, the new country, and he asked the president to mandate vaccination of the warriors at that time. All right, this is how it was called, virilization, and this is the name that was following the smallpox virus at that time. So I'm going to add, here is a chart that a lot of you have seen before. This This is a mandated, mandatory vaccinations that are applied today to every child in this country. I don't even have the adult chart here, but this is what we do every day in pediatrics. We are believers of prevention and use this marvelous tool to make sure that we preserve. Our job is always to make sure these children have a wonderful adult life and with maximizing their capacities and their health and well-being. And this is one of the ways that we always have, and is the main tool that we have to preserve health in a lot of ways for children. And why do I present this is because I believe that the COVID vaccine is now going to be mandated for adults, but is in the future may be mandated for, it will be in this table for children. And I do like the perception that is very similar, even though it's a new way of creation of vaccine, and I'm going to talk a little bit about that, but it still have proven to be safe and very effective. So which are the vaccines? We already talked about them. Pfizer vaccine, Moderna vaccine, Johnson & Johnson. We have few recommendations that Pfizer is every 3 weeks, Moderna is every 4 weeks. Pfizer was approved for 12 people and older, and Moderna is coming back there. And one of the things I want to make sure where I practice in DC, children 12 and older can consent for the vaccine. So this was already approved in the District of Columbia in December 2020. So it has made easier for us to vaccinate younger people like teenagers. And we don't need the parental consent that was mentioned before by Dr. Norris. So I just want to clarify that, because for our practice, it had made it very easy in that perspective. Why we go to schools and we can do that. We can also find people in the community that are younger than 16 and they can still consent for the vaccine. So one of the things is, I always tell people the best vaccine is the one available for you. These vaccines are very highly effective and efficient in some way. I want to make sure if you have an arm and you haven't gotten the vaccines, please get the one you find in your neighborhood. So I added this table that I think is very important, because there's a lot of questions about why I'm going to have this vaccine if it was created in such a short time. The coronavirus vaccine was, as you know, started the process of creation when we had the epidemic in the US. So in the US and globally, actually. So one of the things I want to tell you, this vaccine was created in a matter of a year, but or less. But I want to make sure that you know that these processes of this research has been going on for years, not only a decade, more than a decade. They did have mRNA. They were trying to do HIV vaccines, and they were using this technique. They found that they have to have a cover with lipids to make sure it got into the body safely. Then in 2005, a team in the University of Pennsylvania, Catalina Karikova and Dr. Weissman as well, were making sure they modify the mRNA. So the mRNA messenger RNA is transporting the gene protein that is the gene that is going to produce a spike protein that they have discovered in 2002, where the first SARS epidemic happened in China and in Canada. In order to, they knew that these spike proteins were the protein that kind of were kind of the weakness of the virus. And then when the 2012 MERS epidemic in the Arabian Peninsula and also in the South Korea, they were also studying this protein as the landmark to produce protection in us. And so they were having this research didn't happen in 2020 or started in 2020. I want to make sure this is highlighted because it is the concept that, oh, you know, they started this research in April 2020 or March 2020, and now we have this vaccine. But it's not. It was happening even much earlier than that. I just want to make sure that with these trials that we have vaccinated millions and millions of people already, as we all talk here, is a very safe vaccine. And I want to highlight that I was, and I mentioned that in my personal story, that I had lived a year and a half in the rainforest in my home country called Venezuela, and they had endemic hepatitis B infection. So before we went there in the 90s, 1989 was the first time I lived there, and we were told, you know, this is a very new vaccine, it's hepatitis B vaccine. It's molecular biology creation. We have already tested it. It was a pretty new vaccine, but because I already mentioned, I am a very preventative brain person, and the team that were there, we all say, of course, we're going to have the vaccine. And we're very glad about that because none of us got hepatitis B vaccine, and we had no major consequences. And today, in 2020, as you saw in my chart, we apply hepatitis B vaccine a few days after you're born in infants. And it's very safe, and we have been doing this for a while. So it's really something that I just want to highlight how important it is to really ask questions about the vaccines, especially we're talking about COVID vaccine, but if you have questions about how this happened that quickly, why people call it the miracle vaccine, I do call it that way. And it still is not something that happened last year. It was cooking progressively. And they put everything together. And guess what? I believe this is the future of creation of vaccines. And because I love vaccines, I think this is a great, great, great tool that we prove to the humanity is going to help us even longer and for other things as well. So I put this image because this is how I see the vaccine. As you see, it gives us a shield when the virus is there. If you are in an area where you don't have a shield, that's where the virus is going to get in and replicate, and now maybe mutate and change to be more aggressive and smarter, and transmit easier. As we talk about Delta virus, and maybe in the future will be other names and other viruses. If we let the virus replicate, they're going to be ready to really attack stronger, and that's what we try to prevent. That's what is called, we need to get to herd immunity. 70 to 80% is really the goal. We haven't reached there. It's only 50% full protection, around 50% full protection, and we all have to have this shield. It had proven that it really made us win this war, and we have to be all together. It's not about one person, it's about the entire globe. I am glad to say that there are a lot of global movements to ensure that everybody gets access to this vaccine. So what do we do to talk about the vaccine? We do have a lot of, have to always collaborate with the person. We ask permission to talk about it, and we also ask, like, you assess how open the person is to get the vaccine at the moment you're talking, and if not, you know, is like encourage, continue asking questions to people they trust, and also make sure that we respond to the questions as much as possible. During this process, you know, it's not necessarily everything that we have talked about it. I had patients that are very anxious to vaccines. As a pediatrician, teenagers sometimes have anxiety to needles, and they don't let you even vaccinate or get labs that are recommended every year. So it had happened to me, adults and non-adults, during COVID vaccination, that people are very anxious. I have a patient that told me that I faint 100%, And I said, I haven't seen that, but let's see. So I accommodated the patient. Make sure I didn't let him stand or sit. He was laying down, and certainly enough, we did the vaccine safely, and the patient fainted. But we were ready to help the patient immediately, no consequences. Patient fainted for very few seconds, and then progressively I thought maybe this person wasn't going to come back for the second dose. And guess what? The patient came back and told me, actually, when I saw him, he fainted again. We put all the kind of alerts in the chart, making sure that everybody, if I wasn't there, knew what to do. And he told me, I came back because I never had this support to my anxiety before you came across to my journey. So he, he made my day that day. But I just want to make sure you mentioned that you have to address not only misinformation and questions that are more universal, but also personal needs that are happening for people to get vaccines as well. And at the end, help always to talk about the misinformation. We got into details of each of them, and you already know more than I do about this. And I congratulate you for passing your test that we did here. And there's a lot of information in the CDC page. I want to make sure that you also ask questions to people who you trust and have work in the science or health environment, or anyone that you trust 100% about this. Please do ask the questions. And thank you again. This is who we are, and thank you for listening and your time.
Thank you, UCLA team and Dr. Marquez. Now we're going to shift gears a little bit and move into our rapid fire. Let me introduce you to Dr. Fagan from the University of Arkansas. Dr. Fagan is currently collaborating with communities to reduce the impact of COVID-19 on racial ethnic communities in Arkansas. So Dr. Fagan, can you tell us a little bit about what's happening on the ground in Arkansas?
Absolutely. Thank you for the opportunity. And I know we're running over time, so I'm going to be very brief. So the Arkansas Community Engagement Alliance Against COVID-19 Disparities is designed to create a COVID-free state in Arkansas where no one is left behind to suffer from the devastating effects of COVID and its unintended consequences like food insecurity, joblessness, delayed care for things like colorectal cancer screening, mammographies, and so forth. Our coalition is designed to our coalition is actually meeting right now. So we have bi-weekly coalition meetings. We have used our community review groups to develop educational messages to encourage people to wear their mask and to also get the vaccine. We have partnered with our food bank to do vaccine clinics in coordination with the distribution of food in our low income and low resource communities. And we are providing funds to community organizations so that they can do the outreach themselves because they know their audience better than we do. So what are the overall rates of COVID in Arkansas? The good news is that the number of active cases are declining. We still have 15,000 active cases that are reported. One of the things we will all run into with the home testing results do not get reported with these state data. So we do not know whether or not the count for the cases where people are doing home tests. So what are the vaccine rates among the general public? Most people know that our vaccine rate is about 44% in our state. So we certainly lag behind many of the states in the rest of the U.S. We are seeing that from June to July, our vaccination rates increased by 3%. From July to August, they increased by about 3%. But from August to September, the rates increased by about 5%. So if we can continue to gradually increase our vaccination rates per month, maybe 8 months from now, we will have caught up with nearing an 80% vaccination rate from our state. Among those people who are still making decisions. There's nothing that we can do about the politics of mask wearing and vaccines, because that's another animal and beast. But we're working with those who are on the fence and who may not have enough information to make an informed decision. We know that among 12 to 18-year-olds, about 37% are vaccinated. So there's a lot of work that has to be done to increase it among that young age group. The state has been offering lottery tickets since May for persons to get vaccinated, but we really don't know that that program is effective. And so when we think about vaccination rates, we're thinking about it not just from the perspective of the general public, but what's going on with healthcare workers. Healthcare workers, their advice to patients can make the difference. And we talk about this idea of delayed decision making or refusal to get the vaccine among the general public, but we have to talk about it among healthcare providers as well. 43% of our dentists in the state are vaccinated, and they have the lowest vaccination rate of all healthcare providers. 51% of nurses, 66% of pharmacists, and doctors have a 70% vaccination rate in our state. We know that policies can facilitate or prevent public health practice from moving forward. For example, our state hospital, the only academic hospital in the state, has not been able to mandate vaccines due to the fact that the governor does not allow us to do so. However, other hospitals in the state, St. Vincent, St. Bernard, Baptist Memorial, Conway Regional Health System, many of those hospitals will be implementing vaccine mandates by October 8th or by November 1st. Briefly, what's happening with cases among the vaccinated and the unvaccinated? Hospitalization rates had declined, but they actually increased over the last couple of days. 42% of all people in intensive care are COVID patients, and the monoclonal antibody treatment has really caught fire. In June, we had 14 people who were being treated. Now we have over 2,600 people being treated, and I think most of you may or may not know that we're running out of the monoclonal antibody treatments nationwide. And so both the federal government and the states are going to start controlling that a little bit more. We know that the Delta variant has certainly affected whether or not vaccinated and unvaccinated people end up in the hospital. As you heard the other speakers say, the good news, even though there are some people who are vaccinated who end up in the hospital, the good news is that most of them are not, and most of those cases are among the unvaccinated. So in sum, our vaccination rates in the last month are up by 5%. Hospitalization rates are over 1,000, but active cases are declining. Certainly, more staff are needed to run all of our hospital systems, and it's not just about clinical staff. When people are out due to COVID or they have to stay home with family members who have COVID, everything gets affected, from procurement to providing patients with food, the hospital cafeteria staff, the cleaning staff who have to put more time into the clinics. And so we have to talk about how the entire system, not just the clinical staff, are affected, because a lot of our systems have slowed down and nearly come to a halt because of the pandemic that we were facing. So thank you very much. I'll stop there.
Great, thank you. May I call you Dr. C? Dr. C, with the mask on, mask off mandate going on in Florida, and with school starting back up again, is your rate going up or is it going down in Florida?
Linda, Dr. Carrasquillo had to leave at the 90-minute mark.
Oh, okay, sorry about that. So I'll move on to Dr. Compretta. Dr. Compretta, can you tell us a little bit what's happening in Mississippi? I looked up I did some research, and I found that food insecurity, Mississippi is #1. It's higher than the national average, especially in rural areas when it comes to food insecurities, and on top of that, it's number 5. It's in the top 5 of the states with the lowest vaccination rate. So, is there a correlation between food insecurity and vaccine, especially in rural counties in Mississippi? Can you tell us what's happening on the ground there?
Sure, absolutely. So as you know, food insecurity has had this twofold effect during the pandemic. One is that COVID-19 pandemic has dramatically increased food insecurity throughout the U.S., especially in Mississippi and our most vulnerable communities. As folks lost jobs and experienced COVID or had medical complications that may have affected their work and their families and their ability to purchase healthy food, we saw an increase in needed food resources. And so that's one issue around food insecurity in the pandemic. And then the second is that food insecure individuals are disproportionately affected by chronic disease, especially type 2 diabetes and obesity and cardiovascular disease. And, in Mississippi, we both have really high rates of chronic disease, and we also have large numbers of folks that struggle with food insecurity. I mean, 1 in 5 adults struggle with food insecurity in our state, and 1 in 4 children. And so we know that those conditions really exacerbate COVID-19, and those folks that have multiple chronic conditions experience more severe illness. And so as we look across our state for those high rates of insecurity and chronic disease, and then we layer COVID-19 on top, we know that we're going to have pretty poor health outcomes with those effects or those intersections of all of those conditions together. As we look across our state, we have a lot of mistrust in the vaccine, a lot of miscommunication. And so putting that on top of food insecurity and chronic disease and our high rates of poverty really has seen a surge in our numbers, especially with the Delta variant in July and August. And it has really hit our food insecure individuals and our low-income communities hardest, and our rural communities as well.
Great.
Would you like me to go into a little bit more about Mississippi or just food insecurity?
You can tell us a little bit what's happening on the ground in Mississippi, yes.
Okay, well, as you know, Mississippi, like I said, Mississippi experienced that Delta surge really in late July and August, and had dire impacts on our state. We've had a total of 400,000 cases and 9,270 deaths. And the surge really exhausted our medical system, and ICU beds were widely unavailable. In fact, we had to have 2 field hospitals established here, the Medical Center in Jackson. One was set up by the Department of Health and Human Services as an alternate care facility for adults who had COVID-19 but did not need ICU treatment. And another one was established by Samaritan's Purse, which is a philanthropic medical organization. And they set up actually a garage ICU here on our campus. Both of those field hospitals have since closed, thankfully, because our numbers have begun to go down. But without them, our medical system would have failed. We continue to experience staffing shortages and are working with our MEMA, our Mississippi Emergency Medical Agency, for contract staffing to help relieve our overwhelmed medical teams. And then on top of that, those rising numbers during that period, we also had Hurricane Ida hit South Mississippi and our neighbors in South Louisiana. And we had a flood of evacuees move north through our state. Thankfully, Mississippi hospitals reported little to no disruptions due to severe weather because those that did lose power had generators and they were able to continue patient care. So we're very thankful that our already stressed hospital system did not crumble during Hurricane Ida. But as we've experienced the Delta surge, it's been experienced obviously by most of our unvaccinated population. And during this time, 98% of cases have been with unvaccinated individuals, 88% of hospitalizations, and 87% of deaths have occurred in our unvaccinated individuals in our state. But we know vaccination provides substantial protection, and in Mississippi, individuals that are vaccinated have a 30-fold reduction in risk for developing COVID-19 and an 18-fold reduction in the risk of death. So we know it is working and are trying to convince many of our residents to get vaccinated. Over the past 2 weeks, we're thankful that new infections have decreased by 32% and hospitalizations have decreased by 23%. And our vaccination rates have seen an uptick. And right now, according to today's statistics, we have 43% of our population are fully vaccinated. Of course, this lags behind the national average, but we're continue to be hopeful that that vaccine upswing will continue. Just to give you a really quick brief mention of kind of what we're doing in the Mississippi Community Engagement Alliance that I lead, we're working really hard to increase vaccinations for all Mississippians and to supply our Mississippians with evidence-based, accessible data about immunizations and the importance of protective health behaviors, because mask mandates are very slow. Some businesses have instituted them, our medical center has, but others have not. And so we struggle with continuing to get the message out that masks are necessary and protective. We've built partnerships across the state. We've worked with our Department of Health to allow community-based and faith-based organizations to work with federally qualified health clinics that host mobile vaccines at their locations. And so basically anywhere in the state we can get a mobile unit to, so we can vaccinate those groups. We've also connected listening sessions and focus groups across the state to really help us identify community concerns and questions so we can develop really targeted messaging for particular communities. And then we've also found that folks really want to hear from local trusted sources about vaccine information. They're trying to sift through so much information that it's really hard. And so those local trusted sources are really important. And so we've engaged and trained about 100 grassroots communication leaders of all ages to help us disseminate COVID-19 information. As you know, our work is far from done, especially in a state with already high poverty rates and food insecurity rates and low health indices. But we continue to promote healthy policies around COVID and vaccination, especially focusing on underserved communities. So that's a real quick synopsis of where we are in Mississippi.
Great, thank you. Dr. Aiken Toby, you are the Community Engagement Senior Advisor for the National COVID-19 Resilience Network, working to mitigate the impact of COVID-19. So can you tell us what's going on the ground in Georgia, especially because you guys are going through this mask off, mask on tug of war?
Yes, thank you so much for the opportunity to share a bit of what's happening in Georgia. And many of the colleagues who spoke ahead of me have shared some of what the reality is like in Georgia. So right now we have 44% of Georgians who are fully vaccinated and 53% have received one dose. So we have a long, long way to go. And you bring up a very important point that we just were talking about over the weekend with faith influencers who really have taken the helm in promoting vaccine communication and vaccine uptake. And that is, unfortunately, the science and the evidence that indicates what works to reduce hospitalizations, illness, and death related to COVID-19 is not leading the decisions surrounding what people should do. We know that from our children all the way to our employers, there's a lot of variability in terms of policy to require wearing masks, and certainly the push to promote vaccination is met with justified hesitancy and a need for us to really leverage influencers who can ensure that our messages are uptaken and that people decide to get vaccinated. So we have a long way to go in Georgia, but through things like the National COVID Resilience Network, and more specifically Georgia SEAL, which I am honored to serve and lead, which is the Georgia Community Engaged Alliance Against COVID, we really are working with community-based organizations, clinicians, researchers, public health departments, anyone who has a stake in turning things around for Georgia to leverage their networks to ensure that we have community co-created education, vaccine confidence, and uptake. And while that 44% is a reality that that shows us that we have a long way to go, through Georgia SEAL, we have directly vaccinated over 49,000 Georgians as well as healthcare professionals. What we know is that it is not certainly only about those who are Black and brown in our state, but as my other colleagues would likely agree, in rural spaces, we're really being strategic about partnering with federally qualified health centers and groups like the State Office of Rural Health and the Georgia Rural Health Association, who have that trust to create safe spaces to continue the dialogue, Linda, because whereas back in April through June, folks who wanted to get vaccinated did get vaccinated, we're at a place now where there are a lot of people who are on the bubble or who still are not convinced that vaccinations are what they need to do. So we have a long way to go. I'm not echoing what my other colleagues have shared, but we certainly are on a mission and have great partners that are helping us to figure out what works.
Thank you so very much, and a special thanks to all of the speakers today. I'm going to turn it over to Nelson. Nelson, I know we're running a little short on time, but you have any questions? We want to hear them.
Yes, it'd be great if we could get through a couple of these questions. Our first question is, how safe is the Johnson & Johnson vaccine? We hear of some deaths due to blood clots with that vaccine. Any information on that?
So this is Keith Norris. I'll answer that. So yeah, that have been, so that's something that can happen with actually with any of the vaccines, but it tends, we've seen more cases with the Johnson & Johnson, particularly in younger individuals. And so that's, now that's more than so that's among COVID complications, right? So if we look at it, we say, well, there are five maybe serious complications out of every million people get the vaccine. With Johnson & Johnson, it now goes up to 8 or 9. That's a big number, but that's 8 or 9 out of a million compared to if you get the COVID infection, where blood clots are very common. And with the COVID infection, instead of 8 of 9 out of a million having a problem, 2,000 people are dying and another 6,500 people are being hospitalized. So it's compared to the Moderna and the Pfizer, the complication rate is higher than those. Some people like it because it's one shot and you reduce the chance of maybe having other reactions that you might require if you have 2 shots. So yes, it's higher than those, but it's much lower than many other vaccines and clearly way lower than the complications and risks that we see with COVID.
Thank you, Dr. Norris. A participant explains that she has several women tell her that they have had cancer or other conditions and that their doctors have advised them to not get that vaccine. Is that good advice?
I'm happy to take that one. I think that's a really important question. We know that cancer survivors are at higher risk from COVID in a lot of cases, and it's actually the opposite. We would strongly recommend that people who have had cancer get the vaccine because of their higher risk and poor outcomes sometimes if they have COVID.
Thanks very much for that response. Someone was also asking that a person who is experiencing long-term effects from COVID, they're afraid now to get the vaccine. Should they just go ahead and get it?
This is Dr. Arlene Brown again. I can take that one, and I would say that there's a lot we don't know about long COVID. Early reports suggested that some people who had long-term effects of COVID actually had those effects, those problems decrease when they got the vaccine. We're just getting reports now that are looking at that more closely. It's not clear if that's the case for everybody, but we strongly urge people to get the vaccine. It does not appear to contribute to the effects, those long-term effects of COVID, and if anything, may improve your long-term outcomes because it decreases the risk of getting COVID again.
Great, thank you, Dr. Brown. One of the participants is asking for a little bit more information about the monoclonal antibody therapy. Is it offered to most COVID-19 patients? Why or why not? And what is it?
So this is Dr. Norris again. So it's a great question. So it's a it's a treatment where where these antibodies have been created that are then infused into a person, and they go and they directly, now you have antibodies that can fight the virus right away rather than have to generate your own antibodies. And so they're usually recommended for people who have early COVID but are feeling pretty sick. So that's frequently where we use those, and a lot of times, and the data has shown that they're helpful in preventing it from becoming really, really sick. So you see many people now going to get or requesting or seeking out to get treatment with the monoclonal antibodies. I also want to say, for people who are still leery about the vaccine, the monoclonal antibodies were created just as fast as the vaccine was created. And you're putting in your body something new, just like you'd be putting in something in your body new with the vaccine. So I see a lot of people have no problem, no concern with the antibodies, which is good, but it's still, it's interesting because the process is somewhat similar to the vaccine.
Thank you, Dr. Norris. We have a couple of questions that are very similar. How long after a person with COVID-19 does it take to get a negative result? And then the similar question is, what if the person was fully vaccinated, gets COVID-19? How long does it take to get a negative result from that?
I'm happy to take this one. This is Lisa Mansfield with UCLA. So this actually recently happened to my aunt, so I'm happy to share a personal story with that. So she's fully vaccinated and had a breakthrough case of COVID, and she retook her COVID test at 10 days, and it still came up positive. Her doctor had her quarantined for additional 7 days, and she recently retook her test on Monday, and it was negative. So it varies by person. However, the CDC does recommend that sometimes you should wait at least 90 days or 3 months until you retest for COVID again. And in my aunt's case, it was like, okay, but she needed a negative COVID test to go back to work. And so the CDC also recommends too that you may have to wait at least 90 days to retest, but your doctor can do a symptom-based type of approach where even though your COVID test may still be positive up to 90 days after being infected with COVID, if you in fact are improving with your symptoms and you don't have any like respiratory or breathing issues, they may do like a symptom by symptom based assessment to determine whether it's safe for you to go back and to work or continue to be around people. There's also data that the CDC showed that usually around after the 10-day mark, which is why they make us quarantine for 10 days if you had COVID, you're less likely to be infectious to pass the virus on to other people. So again, it varies by person. Don't be alarmed if you already had COVID that it's still positive well after you've improved from your symptoms, because it could take up to 3 months to not showing your body. Now, if you did get the vaccine, your test can still show up negative. It's just that you may get like the antibody test, which is like the IgM or IgG or IgG test. That will show positive because you're actually showing that you have antibodies to the vaccine, which is what or to the virus, which is what we would like to see.
Thank you, Dr. Mansfield. And I know you all addressed at the beginning during the quiz the microchip myth or question that's out there. But what if somebody says, well, yeah, the microchip doesn't fit in the, it can't be done. But what about the nanochip? Somebody says, well, how do you? Is there more information to respond to that?
Sure. This is Keith Norris at UCLA. If the government wants to follow you, they just follow you on your iPhone, your Instagram, Twitter, or whatever other accounts you have. There's plenty of ways people can follow you if they want to follow you. They don't have to worry about trying to put it and fit it into these little nanoparticles or things like that. So no, there are no chips in there, and there's nothing related to 5G. And if people want to be, if government wants to follow people, they can follow people, and they do, you know, they're following people. And the last thing I'd say, and if you're that worried about being followed, maybe you should stop doing some of the things you're doing that's making you worried about being followed.
Thank you, Dr. Norris. That seems to be very sensible advice. Thank you. We'll wrap up shortly, but a couple of quick questions. Is it safe to not wear a mask around family if everyone has been vaccinated?
I'm happy to take this one too. So right now for fully vaccinated people, the CDC is recommending that you still wear a mask indoors or in places where you're highly, like there's a lot of people around you. And so within your family, if you're all vaccinated, that's great. You're all be indoors, that's also something to consider. For the most part, you don't have to wear a mask. However, if it's a large family and you're thinking about family members who maybe work as essential workers and there may be a risk of getting the Delta variant or being exposed to COVID, that's things to consider. And particularly too with children who are not the 12-year age mark yet, who cannot get vaccinated, although the clinical trials right now are trying to get it out for 5 to 11-year-olds. It's something to consider as well because they may also not be vaccinated and you want to protect them as well. But for the most part, if you are fully vaccinated, you can not wear a mask amongst your family, but in indoor places where there's a lot of people and there's a high contact that people can have with COVID, they recommend wearing masks indoors.
Thank you, Dr. Mansfield. The question here that I have now is, are there similarities in the modality of the vaccine and the monoclonal antibody treatment?
So I'll answer that. This is Dr. Norriskin. Not really. I mean, technically, no, right? So really what the vaccine does is it says to your body, this is what the protein looks like on the coronavirus, and please make antibodies for that so you're ready in case you get infected. The monoclonal antibodies is a little different. Now what you're getting is antibodies that have already been generated to attack the virus. And so you're getting an infusion of prepared, ready antibodies that can go straight to the virus and start fighting the virus rather than having to wait for your own body to prepare it. And because it only lasts a certain period of time before those go away, but that still can be very helpful, particularly early on. And so you don't get the type of immunity with the antibodies that you get with the vaccine, but it does help to fight the infection. And so, and another important thing is, I think if you've gotten monoclonal antibodies, that's one of the few instances where now you should wait more than 3 months before you get vaccinated. Okay, so if you've had monoclonal antibodies, then you really need to make sure you let your doctor know and double check. But my recollection is that in that instance, then we want to wait more than 3 months to get the vaccine.
Thank you, Dr. Norris. And this will be the last questions. If there are other questions that haven't been answered, feel free to send them to us by email and we'll see if we can get some answers. But the last question, and I think it's a good sign that a lot of people have questions about what to do, what vaccinated people can do. And this is when a vaccinated person gets COVID, when are they no longer infectious and ready to go back to work? What should they plan on?
I can answer this. This is Lisa Minsville again. So I kind of answered that one question before in a situation with my aunt. So it depends on your job though. So your job may say you're not allowed to come back to work until you have a negative COVID test. So the CDC's recommendations for vaccinated people anyway who are vaccinated but then get COVID, you still have to do the quarantine for 10 days. There isn't recommendations to retest. However, if your job requires it, then you might as well go ahead and get another test done. But just be cautious that, it could still show up positive, although you're not infectious. And so that's why there is a like a work type of thing that they're doing, where they're doing more of like a symptom assessment. So that would be something that you will work closely with your provider. If you are one of those people who did the 10-day quarantine, your symptoms are improving, but your COVID test is still coming back positive. So for the most part, if you're fully vaccinated and you get sick with COVID and you're infected with COVID, you'll need to quarantine for the 10-day minimum, may need a retest for your job based on their guidelines, and then work closely with your provider to see when it's safe for you to go back to work. But the studies that have been done so far, it shows that probably after 10 days or more, you're becoming less infectious with spreading the COVID virus, even if your does show a positive beyond that quarantine day.
Thank you, Dr. Mansfield. Back to you, Linda.
Great. A special thanks to our amazing panel. Join me in sending the love to them. Thank you, Dr. Akintobi, Dr. Fagan, Dr. Compretta, Dr. Mansfield, Dr. Brown, Dr. Norris, and Dr. Marquez. Thank you for spending time out of your day to be here with us. Again, a special thanks to our sponsor for giving us the opportunity to present this webinar. If you would like to contribute to Consumer Action, you can just write us a check and mail it to Consumer Action, attention given, at 57 Post Street, 6111, San Francisco, California. And again, another way that you can help us is by subscribing. As I said, the video, the webinar was recorded and everything will be available tomorrow. So when you get that link, just subscribe to YouTube, and that would help us as well. And again, a special thanks to our panel, our fantastic audience. Thank you for joining us. And one last thought. When it comes to your health and the health of your family, please get verified facts and advice on how to protect your family from a trusted source like your doctor or a local health authority. Don't play Russian roulette with your family life. If you see something on Facebook, say something. If you see content online that you believe is false or misleading, step up and report it. I can't wait to get back to see you in person. So thank you so much for attending, and check your inbox for the next invite. Thank you. Goodbye.